Isn't it matching our mobile with the same cover? Exactly original. And the cat.
So, good afternoon, everyone in India, and a very early good morning to everyone in USA. We welcome you all to OrthoTV Online. This webinar is held under Navi Mumbai Orthopaedic Association (NMOA), and today our international speaker is Dr. Adam Yank. His assistant, he's an assistant professor in Yash University, and he's assistant director of Cartilage Restoration Center at Rush. He's also the director of Patello Femoral Center at Rush. Besides that, he has got a special interest in advanced arthroscopy, shoulder replacement, and his special focus is on patellofemoral dysfunction and cartilage restoration. He completed his training at Rush University Medical Center, including sports medicine fellowship and a Ph.D. in the Department of Biochemistry, focusing on cartilage restoration. Now, 6 years into practice, Dr. Yanke is an active member of International Patellofemoral Study Group and the International Cartilage Repair Society, and he was selected by the American Orthopaedic Association as an emerging leader. He has published over 100 peer-reviewed manuscripts and presented over 200 abstracts at national and international meetings, and continues to be active in both clinical and basic science research. He is also one of the team physicians for the Chicago Bulls, Chicago White Sox, Chicago Fire, and DeBall Blue Demons. Welcome, Dr. Yankee. Besides
Thank you
that,
for having me.
on the panel, we have Dr. Sandeep Deore. He is associate professor in D.Y. Patel Hospital and has special interest in arthroscopy and sports medicine. We also have Dr. Sanesh Tuteja. He is FRCS from UK. He is right now into active practice in UK, and his special interest is also sports medicine and arthroscopy. We also have Dr. Prasad Chaudhari. He is a professor in D.Y. Patel Hospital and Medical College in Navi Mumbai, and his special interest is trauma and arthroscopy. So without wasting further time, I hand over to Dr. Adam Yankee to start his presentation.
Thank you very much. Thanks for that great introduction, and thanks for having me. And hopefully I can go over some stuff that's useful. My talk is on patellar instability, and this can be a large topic with a lot of different things that we can cover. And there's some very specific things that I would like to focus on. The things that I think are really important when we're treating patellar instability or understanding the anatomy and different aspects of the MPFL, the MQTFL, and the LPFL. And then obviously all the other associated pathology that has nothing to do with the soft tissues for overall alignment. And then I'll try to go through some cases at the end just to try to solidify some of these talking points. So I'm not really going to cover first-time dislocations, non-operative management, or technique details. There'll be some technique aspects, but most of this is going to focus on the aspects listed above. When we think about it, another way to word this talk is the MPFL really all that we need? How often do we need to do more than that? And really the lion's share of patients are probably treated and are well served by a well-done MPFL. And adding other procedures on top of that is not necessarily always worth the risk in the recovery. And I think that's what's the question we always need to ask is how much more do we need to do? But at the same token, how do we do an MPFL really well? And what are the different factors that are important to consider when we're doing that? We've also learned through the work of others that I'll talk about that it's not just the MPFL, it's also the MQTFL, which is part of the medial patellofemoral complex, or the MPFC. There's also a lateral patellofemoral complex that's just as important in medial and lateral translation, and it has multiple components, but the LPFL is arguably the most important one on that side. And then, of course, we'll get into some aspects of associated pathology. When we think about this anatomy, we want to think about its attachment points on the different soft tissue and osseous attachments, but we also want to think about the length changes because almost none of these ligaments are isometric, and so they always either loosen or tighten with flexion, and mainly loosen and at different degrees of flexion. So let's start with just getting into some of the femoral anatomy, and we're going to go through some of other people's work as well as some of the work we've done to further understand this. And so the attachment of the medial patellofemoral complex on the femur is typically at a saddle point just posterior to the adductor tubercle and to the medial epicondyle, or just directly distal to the adductor tubercle. Surgically, this is important because these are palpable landmarks, and so typically I'll make a small counter incision to palpate the adductor tubercle. Then we go just distal to that, and then once you're off of the ridge of the adductor tubercle, excuse me, typically you'll be sitting near the saddle point for the MPFL, which should be its native anisometric point, again, and we'll get into that later. And ideally, when you take a pin here surgically and mark it, once you place your pin, sometimes the medial epicondyle or the adductor tubercle can be difficult to feel. But once the pin is in place, you should be able to move just proximal to that and really palpate the prominence of the adductor tubercle, and then move even proximal to that and palpate the adductor tendon if you don't visualize it directly even. The other anatomy that's important for the femoral side is I use topographic landmarks like the tubercle of the adductor and the medial epicondyle, but then I do also use Schottle's point for overall guidance. I think it's also important here to note that if you look at this publication, these red dots are the different MPFL insertions, and it's really a cloud of insertions, and it spans almost 10 millimeters. And so we talk about how accurate we need to be for this. But just know that there's a lot of variability from patient to patient. And so I think X-ray is more of a guideline to help get you in the right location. And then we use anatomy and length changes to get you in the most accurate location. And so if we take this and overlay a normal X-ray or a perfect lateral, which is obviously very important to obtain in the operating room, we know that this point is typically based off of a line through the posterior cortex of the femur, and then a line through basically the bottom of the notch where Blumenstadt's line ends. If we take a second line now and we look at why is this point important? Well, it's important because it's the native anatomy, but it's also important because of how it affects the length changes of the graft. And so if we take a line from that point seen here in green and take it up to the anterior aspect of the trochlea, if I keep this line now the exact same length and I rotate it down, then it ends up being longer than the trochlea at 90 degrees of flexion, and you can see that that's on the order of a few millimeters when we start near the entrance of the trochlear groove. So that means that that ligament, if we put it at that location, is going to loosen approximately 3 to 5 millimeters if we're at that spot. And that's why the location is so important, because we want to get these length changes correct so that the graft doesn't tighten in flexion and also doesn't loosen too much in flexion. So either of those, I think, could be a problem, with obviously tightening being much worse. So the MPFL and the MQTFL form the MPFC. And so if we go look now on the patellar and extensor mechanism attachment, half of the attachment is really osseous, and the other half is in the soft tissue or in the quad tendon. And this is work through Corey Edgar, Miho Tanaka, and John Fulkerson, and they've really helped draw attention to this. Part of the question is, why do we need to look at this? Why was this even of concern, and why weren't we just sticking with an MPFL? Most of the outcomes for MPFLs are very good. Our complication rate has decreased significantly. Redislocation rate is very low. It's in the single digits in almost all studies. And the return to sport rate is as good as ACL, if not sometimes better. But the concern was this reoperation rate and being related to fractures. And are we placing too large of tunnels in the patella for our osseous fixation? And is that putting patients at risk for outcomes that are fairly devastating? When we look at the literature of how to avoid patellar fractures, it does seem that this work by Aaron Critch noticed that if you use cortical fixation, you're typically pretty safe. There's certainly some technique aspects there, but large socket fixation has a much larger risk for fracture. The approach that they took with Dr. Fulkerson's group was another way to avoid it is just not to put anything in the patella at all. And so he helped pioneer something called an MQTFL, which is a quad tendon-based reconstruction that's all soft tissue on the patellar side, which has been his technique of choice for several years now and has helped popularize this. So this doesn't have any risk for patella fracture, but what's the functional relevance of the quad insertion? So that's been something that's been of interest to me. And if you look at the illustration here on the left, the MPFL inserts on the proximal half of the patella and the osseous component of the patella. The MQTFL is the other 50% of the medial patellofemoral complex, and it's about 1 centimeter into the quad tendon. And so half of the complex is above the superior medial pole of the patella, and half of it is below. But the question is, how much does this affect, well, first of all, what are the length changes of the quad tendon component compared to the patellar component? And then also, how does this affect biomechanically? How much of a restraint to lateral medial translation is the quad component compared to the patellar component if we're going to consider making changes in technique that are fairly significant? This is some length change work that we did looking at the native patella. So this is at normal patellar height. And this is looking at the change in length from the femoral attachment to the patellar attachments at different locations along the extensor mechanism. So you can see that the orange line is the most proximal aspect of the quad insertion, and the blue line is the most distal aspect of the MPFL insertion, which correlates with that image that we see over on the left. We see that all of these lines are slowly decreasing. But then we also see that if we look at the most distal aspect, the amount of change that you have in length from 0 to 90 degrees is on the order of 2 to 3 millimeters. So it's fairly small. It's almost isometric with no length changes. If we look at the quad component as an example that's on the more extreme end, we see here that that change is almost 12 millimeters from 0 to 90 degrees. So there's much more drastic length changes the more proximal you go on the extensor mechanism. The other thing that's of interest is that most of these length changes happen in the first 40 degrees of flexion, which is really where the MPFL has most of its activity. So the goal of the MPFL, which we'll get into again later, is just to hold the patella in the right location until it gets in the groove. And so if you have anything that puts that location more proximal, it has to work for a longer distance before it's assisted by the bony constraints like the trochlea. And so this is a little bit of a concern. This also is just normal anatomy. So if you have a reconstruction, which I'll mention some technique aspects just related to this, that you would like to be able to set the length of, if you're going to do a double limbed reconstruction, of each of those limbs individually. And so for me, that's using 2 separate free ends of the graft for fixation, final fixation, not the loop end of the graft, because I think it's harder to obtain the separate anisometry that you would want to get in that setting. This was a study we did looking at the biomechanical contribution of the MPFL and the MQTFL. This was a cadaveric study, and if you see just below the black line, you can see how there's a stout ligament that forms when you put the patella under tension. So the patella is on the left, the trochlea is on the right, and we're looking at this with the anterior aspect being on the left and the posterior aspect of the knee being on the right. And what we did was sequentially section either the MQTFL first or the MPFL first, and we had paired knees where we did it opposite on each side. And then we did complete sectioning to see if this is really a structurally important part, or is it something that we just see on our anatomic dissections. And so what we found was the native state was actually just a lateral release because we needed that to be able to get into the joint. And once we did that and released, we actually saw that when you look at the amount of change overall, it was about a 10% increase in lateral translation just with the lateral release alone. And so that's something else that I'll talk about more, but that's something that I'll harp on, which is the lateral side also prevents lateral translation. It doesn't just prevent medial translation. And then when we release the proximal half of the MPFC, which is the MQTFL component, we saw almost no increase from intact. So 1 to 2%, no significant increase. When we then sectioned the distal aspect, we saw a 25% increase in lateral translation. And then when we sectioned the entirety, we saw a 40% increase in lateral translation. So what that means is that if you were to injure the MQTFL on its own, it really would have no functional effect. It's the osseous insertion that is the strongest and has the largest restraint to lateral translation. And we did not see as significant of a difference when we released the MQTFL after the MPFL was already sectioned. And so I think this only further reinforces that the osseous insertion is a much stronger component to resisting and is the primary component to resisting lateral translation of the patella. This is just slightly more detail looking at the changes in length, the changes in resistance to lateral translation in millimeters. So this is how far we had, how many millimeters it translated laterally with a fixed load of 20 newtons for the different sections that we just talked about. So this is intact, and so you can see that the MPFL is acting really throughout flexion, but less as you get into deeper flexion. And then if we add on lateral release, we see that lateral release actually increased translation significantly in full extension, but had less of an effect as you started to flex the knee more. Again, when you add the MQTFL sectioning, at every degree of knee flexion, there was no difference in translation with that addition. When we added the distal aspect, you can see that it actually increased at all degrees of knee flexion. So even into flexion, where it should be engaged in the trochlea, it still can play a role depending on the morphology of your trochlea. And then again, addition of complete sectioning, only some difference in extension from 0 to 20 degrees. And so I think that there's a few take-home points from this that are important. One of them is that we know that there's an osseous and a soft tissue insertion of the medial patellofemoral complex, and that there's significant difference in the length changes from the proximal to the distal extent of that. We also know that the osseous insertion is the primary restraint, not the soft tissue insertion, and that the goal for the clinical outcomes are to decrease complications, improve subjective outcomes, and improve our objective outcomes, which is a lack of redislocation. And we want to be able to accomplish this no matter what reconstruction we do. And for future directions, we need to figure out different biomechanical properties of these soft tissue and osseous reconstructions. And we have a study that we're about to publish on that, and another group just published a study in AJSM. And what we found, both authors found, is that the osseous-based reconstructions are also less forgiving than the soft tissue-based reconstructions. So that if you get the MPFL reconstruction wrong, where you're doing osseous-based insertions, you end up with much worse contact pressures, much higher stress and strain on the graft, and it can be much worse. So it does seem like the MQTFL is more forgiving, but there's no clinical outcomes yet on the MQTFL, and that's something we're trying to help get out there. So here's some, I know that's a lot of detailed anatomy and biomechanics, but this is why I think that they're clinically relevant. So this sounds a little redundant, but I'll also just say what this leads to. So we know that the length changes are different, and so because the length changes are different from proximal to distal, as I mentioned, I use two separate limbs going into my tunnel for final fixation in the femur, because remember, you cannot tension ligaments differentially within the same tunnel, but you can set length differentially, and there's a big difference here. We're not applying tension to our reconstructions, we're only setting the length, or the native length. The longest distance for all of the points essentially are in full extension. So every aspect of that gets shorter as you flex the knee. And so for that reason, I set my length of my MPFL in full extension with the kneecap as proximal as it will go. That's different than people setting their MPFL at 30 degrees, 60 degrees, or even 90 degrees. I think that there's some technical differences in how you do it, but I also think that when you are setting the length in flexion, you are putting strain on that graft when you extend the knee, even though it's then out of the trochlea. So it might be safer for the patient with regards to not over-constraining the knee in flexion. But my concern is that those grafts will loosen because they see increased strain and extension, and they'll eventually become loose because of that, and then you'll have a higher risk of instability. Also, Since the MPFL is the primary restraint, I still prefer an osseous-based reconstruction. I don't perform the MQTFL unless it's a revision or some complex situation. But it is nice to know that that option seems to work. And that finally, cortical patellar fixation does have an extremely low rate of patella fracture. And there's a couple technique aspects here that I'll mention. But I use small 3 millimeter anchors that are unicortical, and luckily have not run into an issue related to that. When we talk about anchor placement, the main reason that you can have a fracture related to anchor placement is penetrating through the anterior cortex of the patella. And so we just want to make sure that you really have a finger on the other side of the patella on the lateral facet, then you're aiming directly towards that if you're inserting any anchors, so you're remaining completely perpendicular. And I think that I've seen surgeons be afraid to get into the cartilage surface, so they'll aim up. And I've seen surgeons be afraid that they're going to break the anterior cortex, so they aim down. And when you end up in the joint or out the anterior cortex, it's certainly not a good day. And so we do want to focus on getting that correct. When we also look at this from the coronal angle, we want to stay perpendicular. That's another way to avoid cutout of the anchors. And so if you're using a superior medial anchor, you want to make sure that it stays perpendicular at the top as well. For my reconstructions, I try to get as much of the osseous space insertion covered. So I place an anchor at the mid-body of the patella, and then at the far superior medial pole, which is right where the quadriceps tendon starts to insert. I take the looped end of the graft, and I put this on the patella side through a trough between these two anchors to try to increase the overall contact on the patella. And then that way you can sew this into the native retinaculum adjacent to the patella as well. And I think allows for more robust healing. The other benefit is you now have the two free ends that are going to go through the femoral tunnel. And so now I've taken the sutures from those anchors and I've clamped them around the pin that I've used as my anisometric point, or my normal anatomic location. And I am pulling posterior, and you can see there's a gap in flexion, and when I extend, the hemostat goes all the way up to the pin, and when I flex the knee, it loosens by about 5 millimeters. And if this patient does not have patella alta, where they have a more proximal patella, then those length changes are appropriate. They should be somewhere between 1 and 5 to maybe 8 millimeters, depending on the patient. And if I was getting 15 millimeters of length change with an osseous-based reconstruction, then maybe my pin is in the wrong location, it's loosening too much. And obviously, the worst case scenario is seeing this loosen when you come into full extension, which is what we all need to avoid, obviously. So that's what I wanted to cover on the medial anatomy. I'm going to switch over and talk about the lateral anatomy now. This is not talked about quite as much and has some very specific relevance. It's not relevant to all patients, except for the fact that we need to respect it in all patients. And that's getting into this idea of a lateral release. And so historically, a lateral release has been performed for lateral patellar instability. And the thought is that it will help the patella ride medially. And the best analogy here is that it's like a horse and their horse's reins. And so you can see in this picture that the MPFL goes directly posterior from the patella, and so does the LPFL. Okay, they do not go side to side. They pull down like this. And so the patella goes back and forth like this, not side to side with the two ligaments. And so if you had a horse and the horse is pulling too far to the right, you don't let go of the rein on the right and pull on the left. You slowly loosen the rein on the right and tighten the rein on the left, because you want to maintain control of the horse. And if you completely let go of one rein, you've lost control. And that's essentially what a large lateral release does. And so we'll talk again about the anatomy of the lateral side. Here's an MPFL, so that's a native MPFL. And then if we come over here, we'll see what an arthroscopic lateral release looks like. And even though these are done arthroscopically now, I wouldn't say that they're any less benign just because they're performed that way. You can still get a pretty extensive release without doing an open procedure. And this is what the native LPFL looks like. This is a patient that has a very well-formed one. On the left, you can see the fanning out of the patellar or extensor mechanism insertion. And on the right, you can see the femoral insertion. And it's really fairly discrete, very similar to the MPFL. This is an anatomic dissection. And again, it's the structure in the middle that's the large fan-shaped structure. And it's really the opposite of the MPFL, where the fanning is on the distal portion of the patella, mid to distal, and then it has a soft tissue insertion on the patellar tendon. So it's more distal, and you can see that on the illustration on the right, that it covers almost the entirety of the bony component of the patella, and then has that distal insertion. This is an arthroscopic video of a patient with, again, a very well-defined LPFL, and you can see how it really matches those anatomic dissections and fans out from the femur. Here's a gross dissection in a patient that was undergoing a patellofemoral arthroplasty, and you can see how well defined that lateral patellofemoral band really is, and you can usually palpate it pretty well also during open dissections. This was some work done with Jorge Chala in our lab, and we did an anatomic dissection to further define the lateral patellofemoral complex. And so we tried to come up with discrete descriptions of where the LPFL is. We also described the LPTL and the LPML. Those are of unclear significance, but you could imagine they're analogs on the medial side. That means that they might be more helpful with patellar tracking in higher degrees of flexion. But our focus was on the LPFL, and the femoral attachment on the lateral side is distal and anterior to the lateral epicondyle, and so it's a relatively distal structure. It's just posterior to the popliteus insertion and just adjacent to the FCL insertion on the femur. When we look at the patellar attachment, we saw that it was about 2.7 centimeters on the patella with almost a centimeter extension into the patellar tendon, so very analogous to the MPFL and the MQTFL. We then looked at the length changes to say, well, how much does this loosen in flexion, or does it loosen at all? And we found that the LPFL actually has significant loosening throughout flexion, almost 15 millimeters, so very similar to what we saw on the MQTFL. And that happens over a period of the entirety of flexion. And what I mean by that is, if you look at early degrees of flexion, there's no greater increase in length changes and compared to later degrees of flexion. So it's basically constantly loosening throughout flexion. We then talked about the horse's reins, and we also talked a little bit about the lateral release effect. So again, we saw that largest effect in full extension, and that just allows increased lateral translation, not to mention that you basically can only get medial dislocations iatrogenically from a lateral release, and that's something that we do run into. So this is a patient that had lateral patellar instability and had a lateral release as a treatment. And you can see how unstable the kneecap has become on the lateral side of the knee. So this is full 90 degrees of lateral tilt and eversion. And when we push the kneecap laterally, we can see that it actually has increased translation laterally and medially, somewhat due to the patient's native underlying pathology, but also exacerbated due to that release. This is another example of a patient who had isolated lateral release. This patient actually had no history of patellar instability. She had patellofemoral pain only. And you can see when we translate the patella laterally, it doesn't just shift over because it has the two connections. It rides up because the one rein is gone, and as you push, it tries to ride up out of the groove instead of having that native restraint. And you can see that sulcus that really develops in the lateral soft tissue from a vacuum effect from the synovium. So for these patients, we can do an LPFL reconstruction. And this is a soft tissue-based reconstruction of the lateral retinaculum or of the LPFL. And there has been several authors that have had reports on the outcomes of these, and they've been very successful. We looked at a biomechanics study of the osseous and soft tissue-based reconstructions. And again, it showed that the soft tissue-based reconstruction was actually more similar to the native LPFL. and also is more forgiving, similar to what the second half is similar to what we found on the medial side. And so this is what that same patient's exam looks like now after the lateral side has been reconstructed. You can see that the patella, even though that incision is there now, it doesn't swing up like it did before. And then we have about 10 degrees of patellar eversion, but nothing more than that. And before it was almost 60 degrees. So that's what I would like to cover with regards to the anatomy, specifically on both the medial and lateral side. I think another big question and a hot topic is the associated pathologies. So what else do we need to be concerned about, and when do we need to be considering other things than soft tissue-based reconstructions? And just because we have a hammer, we don't want to treat everything like a nail. And so the MPFL is very good, but we need to always think about what else we should be considering. And we should always have a clear understanding of what lies beneath the surface. And that just means that we don't want to miss understanding how to evaluate other pathology, even when we're not going to treat it. Because the more that you get used to having a routine evaluation that you do every time, the less likely you are to miss something when it's significant. And then the better understanding you have of what's truly normal and what's truly abnormal. This example on the left was a young teenage girl that was sent to me who had 2 prior MPFL reconstructions. You can see on her x-ray that her tunnel is slightly anterior. I wouldn't say it's terrible, but it's certainly not anatomic. And they said that she needed a 3rd MPFL reconstruction. And her Canton de Champ ratio, which is the measurement I prefer for patellar height, was 1.38, and we know the upper limit of that is 1.2. And I have no issues, and we'll talk more about this, but I have no issues with performing an MPFL on this patient the first time in isolation. But at this stage, we should be able to recognize that that patella alta can be a risk factor and should be corrected at that stage. This other girl on the right, which is the CT scan, is 12 years old. She had a MPFL reconstruction and failed. And again, they were going to do a revision MPFL. You can see that we're looking at an AP of the tibia, and look at where the femur is located. So it's pointing almost directly to the right because this patient has severe femoral aneurysm. And so that's something that needs to be addressed at this stage if the soft tissue reconstruction alone has failed. So what associated pathology matters? There's a lot of alphabet soup here where there's a lot of abbreviations and confusion, and how do all these aspects contribute? And the way that I try to separate this out in my mind, because I can't understand it in that format, is that we have medial reconstruction, in whether it's an MPFL or MQTFL, an adductor sling, whatever you want to perform. And then these are the other procedures that exist. Things to correct tibial torsion, a lateral tuberosity, which is essentially a tibial tubercle osteotomy, or Fulkerson, patella alta, dysplasia of the trochlea, the lateral soft tissue, which could be a lateral lengthening potentially, or a lateral reconstruction if necessary, valgus, and femoral aneurysm. And so while there certainly could be some other nuanced ones beyond this, I think that these are the main actionable items. So if somebody has ligamentous laxity, that could be a risk factor, but there's no surgery to correct that. So these are focusing on surgical factors. What can you add to improve your outcomes, and when should you do it? And so ideally, we should have a rank order algorithm where you can put in all the patient's preoperative anatomy. You have a risk assessment, and you say, like, this is what we should do, this is what we shouldn't do. The reality is that doesn't exist. And so this is the best guidance that I think that we have at this stage. It's good to categorize these and understand how you're affecting the tracking of the patella. And so when we talk about tibial torsion, femoral aneurysm, and valgus, I would consider those global factors where we're looking at overall maltracking of the patella. Whereas if you look at alta, dysplasia, or LPFL deficiency, we're now talking about local issues directly related to the patella tracking, but also patellar translation more so. So if you wanted to correct how the patella was tracking, moving the tibial tubercle is going to be a much more powerful procedure than changing patellar height, for instance. Now, that is that lateral tuberosity, which is sitting in the middle, and it kind of floats in the middle because it is a global factor and it's a local factor. And so I think that it does have an effect on both, and that's one of the reasons why tibial tubercle osteotomies can be so powerful, and sometimes to even overcome significant dysplasia without correcting the dysplasia. So when you take the knee from full extension into flexion, there's just a few goals. When your knee is in full extension, you want the patella to align with the trochlear groove before it engages in the trochlea. And so while the MPFL can play a role for that, you don't want the medial reconstruction to pull the patella over. You're not supposed to put strain on your graft in that way. And so it's really the osseous components that are going to control that. So it's those larger global factors that are really going to have the largest effect. So if the patella doesn't align with the trochlea before it engages, then clinically you end up with a J sign. So if you have a significant J sign, then you either have a lateralized tubercle valgus and potentially significant dysplasia, especially if it's like a jumping J sign. So when we look at this clinically, the Q angle, which goes from the ASIS to the patella to the tibial tubercle, anything that increases the overall lateralization force on the patella, whether it's overall valgus, as I mentioned, or tibial tubercle, puts an increased lateral load on the patella. The measurements that we have to evaluate this are now the new version, so to speak, of the Q angle is the TT-TG distance. And so that takes a line from the depth of the trochlear groove to the insertion of the patellar tendon parallel to the posterior condylar line of the femur. And we measure that, and that is our TT-TG. So that is our kind of radiographic or MRI Q angle. We then can look at distance between the PCL fossa medially and the patellar tendon, and that's the TT-PCL. So if we want to know specifically how much the tibia is contributing to an abnormal TT-TG, then the TT-PCL is helpful for us to understand, is it related to, is having a significantly abnormal TT-TG because the groove is not in the right location because of dysplasia, or is it because the patient actually has a significantly lateral tibial tubercle? And so through measuring dysplasia individually and through measuring the TT-PCL individually, we can help understand where this deformity or abnormality is coming from. We then want it to not only line up with the trochlea, but we need it to engage at the correct amount of flexion. And so if the patella is not engaging in high degrees of flexion, it's usually related to patella alta, or there also can be a component related to dysplasia, which I'll talk about as well. So you can imagine that when patients have a significantly increased patellar height, and we take a look at this on an X-ray, when we take the functional component of the trochlea, we normally don't get engagement until about 30 to 40 degrees of flexion, depending on the patient, typically 30 or less. But if you have increased patellar height, you can be in a high degree of flexion, but still have no osseous-based restraint. That also means that your medial patellofemoral complex is going to loosen relatively more because the patella is more proximal. And so that was something that we also looked at with regards to length changes. And this is a graph looking at the length change from 0 to 90 degrees at 4 different patellar height settings from a CDI of 1, 1.2, 1.4, 1.6. And the most important part here is that the orange line on the bottom is the most distal aspect of the MPFL. It stays with the same length changes at 1, 1.2, and 1.4. So that actually doesn't significantly loosen until you have a patellar height of 1.6, the ratio. Whereas the most proximal aspect, which is the blue line, increases significantly at all increases of patellar height. So the concern is that more proximal-based reconstructions may be prone to loosening much more significantly in the setting of patella alta, and that having a relative distal reconstruction might be helpful in patients with alta without performing a distalization. So sometimes it could avoid that. So it needs to engage in the right angle, and it needs to have something to engage in. So what I always treat to our residents is that if somebody is at 90 degrees of flexion and you can dislocate their kneecap, they have a high likelihood of either having severe alta because it's just not in the groove, or they have severe dysplasia and there's just no osseous constraints once they get down into flexion. And trochlear dysplasia is a whole separate topic that can be complicated, but an easy way to think about it is, do we have a convex groove? Is it flat or is it a dome? And then is there a large spur or not? And those help guide treatments because we can either pick from an entrance trochleoplasty, which is a bumpectomy, or a groove deepening trochleoplasty. And I don't have a lot of it in this talk, but I would just briefly mention that if you have a severe J sign where you're having problems with entrance into the groove, then that's when a trochleoplasty probably makes the most sense. Everybody has a groove once you get far enough distal into the groove. It's really that entrance component that's the issue. And then finally, we haven't talked about it much here today, but the overall dynamic control of the leg, the abduction strength, the external rotators, those are super important both before and after surgery and should not be ignored in these patients. So I have cutoffs for these different measurements where I start to pay attention to them when they get beyond that. This does not mean that I correct everybody that's outside of these bounds, but if their measurements are outside of these numbers and I take those into consideration, then I look at those relative to the entire patient and then make a decision on whether or not I need to correct these factors. And so we're getting a little bit towards the end of the talk, and I'll just go through at least one case if I can, and then I'll give you time for questions also. But it's pretty clear that we need to get it right the first time if we're doing an MPFL reconstruction. If it fails, you want to know it failed because of some other pathology or anatomy we didn't correct, not because we did a bad job with the reconstruction. And getting the femoral tunnel location correct time and time again is shown to be the most important aspect to really focus on. There's also some, this study is another one that demonstrated that where they showed in low-grade dysplasia that the location relative to Schottle's point is the most important. When we look at which factors increase the risk of failure after isolated MPFL reconstruction, it's confusing. So we have studies from well-known authors that say 100% failure rate in high-grade dysplasia versus less than 5% failure rate in high-grade dysplasia. So how do you reconcile that? Now, this is a study that we have in PRESS and AJSM, and what we did was take all the literature that looked at isolated MPFLs and we separated them out into two failure modes, frank redislocation and PRO failure. And so only 3 studies have really looked at the risk factors associated with redislocation after isolated MPFL reconstruction. And this table shows that if there's a check, then they controlled for that factor and they found it was related and significant. If there's an X, they didn't look at the factor. And if it's a blank box, they controlled for the factor, but they didn't find it to be significant. And if you look at the trochlear dysplasia column, you can see that every one of these studies looked at that, and 2 out of the 3 studies show that trochlear dysplasia increases your risk for redislocation after an isolated MPFL reconstruction. Only 2 of the 3 studies looked at patella alta, and only 1 of them found that it was significant. And the one that found that it wasn't significant had controlled for more factors that are relevant than the one that didn't. And so I would argue that patella alta may play a role, but I certainly don't think it's as significant as a lot of us talk about it, and that I do not distalize somebody just because they're above 1.2 for the CDI ratio. This is a much busier slide, and I'll try to simplify it. This is a similar table, but using PRO for failure or patient-reported outcomes, not redislocation. So most of the literature looks at PROs, not redislocation. And if you look at the study at the bottom, it only controlled for 1 factor, and it didn't even look at all the other factors that other studies have shown are significant. If we look at the top study, this one controlled for almost all factors that are known to be significant. It found that only 3 were relevant, but it was a very good study because it looked at the most factors. And in that study, it was the age at first dislocation, bilateral symptoms, and femoral tunnel location that were the most important predictors for failure of an isolated MPFL. When we then look at it the opposite way, almost all studies controlled for trochlear dysplasia except for 2, and only half of the studies that looked at trochlear dysplasia showed something significant related to it. And if you notice, the 3 that showed that it was relevant didn't control for, excuse me, the other factors, and controlled for much less factors than the other studies. When we look at femoral tunnel placement, only 3 studies controlled for that, and all 3 studies that looked at it found that it was significant. So I think that that's a very important take-home here, is that we should get used to always measuring all of these factors on everyone, even if we're not going to act on them. We should try to perform the best reconstruction that we can so that we don't cause a complication and we have a good outcome. And then finally, we should only consider these complex osteotomies in patients that are revisions or have severe abnormalities. And again, I have 3 cases, but I'll use this time just to do 1 case briefly, and then I'll leave some time for questions. And if you'd like me to go through the other 2 cases, I can certainly do that, but they just try to highlight some of these points. So the first case here is an 18-year-old who had recurrent instability. He had a history of Down syndrome, and he has several atraumatic events per month, even when walking and doing low-level activity. He gets some benefit from a patellar stabilization brace and is looking for a permanent solution. He has 2 quadrants of lateral translation and a 2-quadrant J sign, and he has no global ligamentous laxity. When we look at his x-rays, we see that he does sublux laterally in full extension, and when he flexes, you can see that the patella engages in the trochlea. So he does have a trochlea that he seems to track into. He just has a J sign. He has 2.5 degrees of valgus and has some mildly increased patellar height at a CD ratio of 1.34. And when we look at dysplasia, I would say that he has low-grade dysplasia, potentially type B or type C in the Deore classification, and is somewhat convex but does not have a bump associated with it. His TTTG is 24 and his TTPCL is 23, and so those are both fairly significantly abnormal, especially the TTTG. When we look at femoral anaversion, it was about 17 degrees, which is slightly above normal, but still within a normal range for me to not be concerned about it. And so this is an example of how we measure everything every time, and then we take these factors and say, what am I concerned about and what am I not concerned about? So for him, his TTTG is concerning, his dysplasia is concerning, or convex trochlea, and his increased patellar height is concerning. When we take this in the relative to this patient as a whole, he does have a history of Down syndrome. He has some difficulty following commands. He would have issues really being strict with a postoperative protocol. And so I thought that in this setting, adding an osteotomy could potentially harm this patient. And he has some factors that are certainly abnormal, but I'm okay ignoring those. And I know that if I have to do another surgery for him, it's going to be a revision MPFL, a tibial tubercle osteotomy that's a distalization and a medialization, as well as a possible trochleoplasty, depending on how he tracks after this surgery. And so he's about 2 years out now and is still doing very well with just that isolated ligament reconstruction. This is how loose his patella was with medial eversion, and then there's lateral eversion. So you can see that his medial soft tissues were really significantly lax, and he was fully dislocatable in full extension as well as in deflection. And this is something that I do like to look at here, so we can see that as we flex his knee down, this is 90 degrees, he's still dislocatable in deflection. And so that's because he has this combination of alta and dysplasia. So there's no doubt that our reconstruction is going to need to act through a larger degree of flexion. But performing a trochleoplasty doesn't give you a new trochlea that deep in deflection. And performing a distalization will help, but it won't help all the way into 90 degrees of flexion when the CDI ratio is only 1.34, because that would be distalizing about 5 to 7 millimeters. And so we try to put all these pieces together to come up with what we think is the best treatment option. The last thing I want to show for him is this is during arthroscopy. I put the camera in the notch at 90 degrees of flexion, and I slowly extend the knee. to try to see what the groove looks like in the middle of the knee or where the notch is located. And so this is in this individual that we saw the images before, and you can see how it's just a complete drop off or a slope. Here's the prominent lateral facet. There is a hypoplastic medial facet, and at the floor of the trochlea, or the deepest portion of the trochlea, is relatively level to the anterior aspect of the femur, which is why he does not have a supratrochlear spur or a bump on imaging. So I will stop there so that I can give you guys time for questions and discussion. I'll jump ahead here to this slide, and then I can always go back as needed. But I just wanted to say thank you again for having me, and happy to go over anything that's helpful. I'd also like to thank Rohan Gala for helping getting me involved. So thank you all very much.
Yeah, that was a very wonderful illustration of the very difficult problem. May I ask few questions, sir?
Sure, of course.
Yeah, you see, for general orthopedic surgeon, there is a consensus on very common surgery, medial plication and lateral release. So what is the status of this traditional surgery, lateral release, which theoretically used to solve many problems of lateral dislocation? So in your opinion, what is the role, what is the current status of lateral release in this patellofemoral disease?
I would say that we're trying to move towards not performing a lateral release for lateral patellar instability really at all. I think it's very difficult to find a situation where it's necessary, and if someone has chronic lateral maltracking in patients with significant dysplasia, then you can perform a lateral lengthening to try to get their patella to track more centrally. But I would say that I think that we're all trying to move away from a lateral release. The difference between an imbrication and a reconstruction is a separate topic, but I would say, and we could talk about that too, but I would say that the lateral release I would try to move away from.
Okay. Yeah.
But we still see it all. We still see it all the time, also. So it's very common.
Right.
Yeah. Hi, Adam. That was a very comprehensive algorithm that you presented for patellofemoral instability. I have a few questions. I mean, I just wanted to know whether there's any role of a standing AP X-rays with the quadriceps pulled up. I mean, do you do that routinely?
I don't. I do have them standing, so their quad is active. I don't have them necessarily doing a strong contraction during that. For me, the AP radiograph standing helps me see if there's any subtle femoral anaversion that I could miss because you'll get an oblique of the femur. You can also see, like in that one case, if the patella is tracking out laterally, and then when they come into flexion, or the flexion PA or Rosenberg view, if it recentralizes, then that might tell you that they actually do have a groove that they are relocating into. So I think it does play a role, but I think that for me, the workhorse is a perfect lateral X-ray, and it's very important to get that X-ray correct because it can be very difficult in patients with femoral anaversion or dysplasia.
I mean, what is the algorithm for a patella baha? I mean, in case of we talked about patella baha.
Yeah, patella baha can be extremely difficult to treat, and it depends on what caused it. And so I have done osteotomies where we proximalize the tibial tubercle, and so you can essentially move it, but it's only a finite amount that you can really move it, and it's about 1 centimeter is the most that I've ever been able to bring it proximal. I've done pie crusting of the patella to bring it more proximal too, but in these settings, it's usually patients that have arthrofibrosis and that they have a very stiff knee. I haven't typically run into patients that have patella baha that's related to their instability of the kneecap, but it could also lead to more flexion-based instability.
There are two more questions. I mean, when do you decide to go ahead with a patellofemoral replacement? I mean, if you find chondrosis in the patella, I mean, where is the time where you can still reconstruct and see whether the patient is still happy, or you go straight away with a patellofemoral replacement?
Yeah, I have a lot of patients that I do patellofemoral replacements. I also do cartilage reconstruction with osteochondral allografts are the ones that I use the most. And I will push the limits of an osteochondral allograft or a tibial tubercle osteotomy, lateral lengthening, possible lateral facetectomy in patients much more than I will do the arthroplasty. So if I have someone who is relatively low demand, they want relief with daily life pain, and they're 50 years old or greater, then I don't mind doing a patellofemoral arthroplasty in those patients. If I have somebody that's that age and their knee is more focal disease, their x-rays are totally normal, then I'll push them, especially if that's what their expectations are, to do the tibial tubercle osteotomy with a possible transplant also, and then the lateral soft tissue procedures. And then of course, if they're younger, I'm going to push them that direction too. So I do have some 30-year-olds that I've done replacements on, but they have clear bone-on-bone arthritis on their x-rays and have very reasonable expectations. So I think it's a combination of how severe the radiographic disease is and what they really want to get back to.
Yeah, and the last question, I mean, what is your protocol for a first-time dislocator who is a very high-demand athlete?
Yeah, that's a great question. Can you still hear me okay? I just wanted to make sure my screen changed.
No, I can.
I actually stopped the screen share so the people on OrthoTV, just a minute, just people on OrthoTV can look at everyone.
Okay. So sorry, my screen just switched over. I see everybody again now. So that's a big question, and I think the shortest answer I can give is that if I'm doing surgery on somebody for a first-time dislocation and they're high demand, I'm doing an MPFL reconstruction, not a reefing. Because if I'm going to be doing it, I want to give them the strongest thing possible. Sometimes our hand is forced if they have an osteochondral fragment, and in that setting, we really want to know, should we just do the reefing or the reconstruction? I've moved to doing primary reconstructions for those patients because I feel confident enough that I'm not going to put them at risk related to the reconstruction or have a complication associated with it. So if this is an in-season athlete, I usually will treat them non-operatively because if you're going to fix it, they're going to probably be out for the rest of the season anyhow. So I give them the 4 to 6 weeks to see if we can get that to tighten up. I put them in a brace. I do full range of motion right away. I never limit motion after a dislocation. And I use the patellar stabilizing brace even though there's no evidence behind that. And if they're off season and they're really a high demand patient, in 4 weeks or so, it doesn't seem like it's tightening up, then I would recommend the MPFL.
Thank you, Adam. Thank you.
Hi, Adam. Sanesh, I had a couple of questions. The first was with regards to your femoral attachment of the MPFL graft. So are you still using the Schott's point, and do you use X-rays to get an accurate placement of your femoral tunnel? That's my first question. And the second one is, as you tunnel the graft from the patella onto the femur, what layer are you putting this? Is your graft subcutaneous, or are you putting it deeper?
Yeah, so those are great questions. I use, for the femoral attachment point, I use Schott's point to localize my incision. So I mainly use it to just make a small incision in the correct location. And because if someone's slightly larger, you can have a relatively long soft tissue tunnel. So you don't want to make that a struggle. So I do that first. Then I actually, as you mentioned, I do my dissection, and I actually dissect from the patellar side down. So when I'm dissecting out the patella and I have my anchors in, I put my graft just superficial to the capsule. So I'm deep to layer 2, and
Right.
I palpate down superficial to the capsule to the adductor tubercle. I open up that recess posteriorly. And then when you repalpate through the incision that you made for the femoral attachment, now you can feel the adductor tubercle and the epicondyle very well. I'll place the pin just distal to the adductor tubercle. I'll check that on x-ray just to make sure I'm not feeling something wrong. I want to be close. Then once I have the pin in, I take those sutures from the anchor and check my length changes. And as long as I'm loosening from somewhere to 5 to 10 millimeters from 0 to 90 degrees, then I accept that spot and move forward. But I really use all 3. And I would just caution you on using x-ray only because you can really get fooled if your x-ray is not totally perfect, and it's very easy to do that.
Right. And any suggestions on how do we get the graft in the right layer, sort of, because we really need to be in the layer number 2 medially, right?
Yes. So I find that, first of all, I use a tourniquet for every time that I do this. I use a 15 blade knife for the dissection because I think a 10 blade or a bovie is just too blunt and ruins the soft tissue planes. And typically, when you're doing your dissection, you're obviously going through skin and perpendicular to skin, but as soon as you get through layers 1, usually you'll see some fat, and then you can start cutting directly towards the patella so that you get down to bone. Once you have the medial aspect of the bone exposed, then you start cutting deep again until you start to see fat again. So a lot of times, unless a patient has ruptured their MPFL off of the patella, you're actually, you're actually cutting through native MPFL because that's not the part that tore. And so usually you can see really nice, obvious fibers coming off perpendicular to the patella. And then as soon as you get through those fibers, you stop. And then you take like a blunt dissection scissor, like a Metzenbaum, and then you slowly start to open that up posteriorly. Because the capsule, as I'm sure you know, is like tissue paper. It's extremely thin, and it's very easy to go through. If you do go through it by accident, you can always just suture it back up to the patella so you can maintain the accurate planes. So it's not a problem if you go through it. I probably violate the capsule about 15% of the time, and I just repair it before I do my reconstruction.
Right. And one more question is, so you're doing a long leg alignment view for all your patients with recurrent dislocation of the patella, is it?
Yeah, yes.
All right. Thank you.
I think you're just still muted there.
In patients, your adolescent girls who are hyperlax with a valgus alignment, how do you deal with them where there is no component to the dislocation?
So you said someone that is hyperlax with valgus and no dislocation?
No bony component. No, there is no trochlear dysplasia, but there is a recurrent dislocation. And regarding the quality of graft you are using, it is again going to lengthen in future. So how do you? What is your experience in that?
Yeah. Okay. So that's a great question, and so it depends on the age of the patient, how severe the valgus is, because if they have enough growth left, we'll do guided growth. So we'll put staples to try to correct the valgus if they have enough growth. Let them correct more, see if they still have instability after that, and if it's gone, then obviously you're done. And then if it's not, then we can do an MPFL reconstruction, and depending on their age, in skeletally immature patients, I will actually typically do my same technique. I just aim the femoral tunnel distal, but you can also do an adductor sling technique. If it's really severe, I typically will not correct or perform an osteotomy in someone that's skeletally immature for that setting, and so I usually will then try to do a isolated MPFL reconstruction and tell the patient that this could certainly stretch out, and hopefully we can get at least 5 years out of it before we can do an osteotomy. But ideally, they're in a category of they're either young enough that you can do guided growth, or they're just old enough that if you wait maybe a year, they'll be skeletally mature, and then you could do a distal femoral osteotomy.
Thank you. Dr. Neeraj, do you have any questions on the?
No, we don't have any questions. That is why I kept 3 panelists.
No, in the chat group.
From the audience, no. So are we done with the questions here from all 3 of you?
Yes.
Okay. Thank you, Dr. Adam Yanke. Thank you for your time coming up early morning on a Saturday morning. And we thank our panelist, Dr. Prasad Chaudhari, who's still in the hospital working on a Saturday, and Dr. Sanesh and Dr. Sandeep. Thank you very much.